Welcome to this webinar. It's the Health Professionals Feedback Loop 1, and this is part of the co-design of the Murrumbidgee LHD Safe Space you're getting to in your region, and this is for the Griffith Safe Space. Thanks, Tina. So I'm Carrie and this is Tina, and we're co-facilitators for Roses in the Ocean, who are leading the co-design of all the safe spaces across all New South Wales LHDs. We're just going to begin with some acknowledgements. So we'd like to acknowledge and pay our respects to the original occupants and traditional custodians of all the lands that we're meeting on. We're aware that when you do things in a virtual environment, that people are in lots of different places, but particularly to acknowledge the Wurundjeri people of the Murrumbidgee LHD region, and also to pay our respects to their elders, past, present, and also to their emerging leaders. We'd also like to acknowledge and pay our respects to any Aboriginal and Torres Strait Islander people who are participating in this co-design process, and to also just to acknowledge the enormous contributions of Indigenous communities all over Australia in terms of the suicide prevention efforts that are underway. Thanks, Tina. In the context of this co-design process of an alternative to ED, we also like to acknowledge people with lived experience. We really want to acknowledge the really uniquely valuable expertise that experts by experience bring to co-design process, particularly in the context of really the systemic change that is trying to be achieved here in terms of developing non-clinical supports for people in suicidal crisis. Thanks, Tina. So just a little high-level overview of where we are so far in this co-design process in your region. So we've had the lived experience focus group conversations, and that's where we brought smaller groups of people with lived experience together, and we had a chat with them about what the feelings and emotions associated with accessing ED in suicidal crisis were like, what were the reasons for that, and what were some of the needs that weren't being met if those experiences were negative ones. We've also then had a lived experience co-design session where we brought all the lived experience participants together for a half-day online session, and we really started to explore. It's really kind of more what we're calling the blue sky dreaming part, where they really brought their best and brightest ideas about what a local safe space would look like, what are some of the values and principles that would really guide the safe space, and also what are some of the things that would meet the needs that they talked about that weren't being met through the conventional clinical system. We then also spoke with health professionals in these smaller focus group conversations as well, and that's what we'll be feeding back to you today. And then the purpose really of this feedback loop is just to provide a bit of context to the co-design process, particularly for people who may watch this webinar who haven't been directly involved in the co-design workshops, to make sure what we have captured has been really captured accurately in the co-design sessions. And also what's really important is to gather those broader views and experiences through this webinar, where people that aren't directly involved can see what's being captured. They can also follow up with a survey, and we'll show you the link to that at the end, and where you can access that. And we really encourage as many people in the community to get involved. We can't have everyone in the room, of course, particularly online. So we really want to get the broadest kind of community consultation here throughout the process. Thanks, Tina. So we know in co-design processes, it's really important to get, as I was just sort of alluding to, a broad and a range and a diverse range of perspectives in the room, but it's also very important to pull focus on what perspectives are relevant to the particular service model that's being developed here. And in this case, it's about, as an alternative to ED, it's about getting people involved, health professionals, service providers who provide that direct service and support to people in suicidal crisis. And so some of the perspectives here is the emergency department CNC. There's also a police sergeant crime coordinator, the MEX clinical nurse consultant. So in your region, you have a particular way of assessing people, and also a youth mental health worker. So a range of different perspectives. Thanks, Tina. And so what those health professional focus conversations were about is that we really wanted to understand what it's like to walk a day in the shoes of a health professional, trying to provide the very best care to people in suicidal crisis, given the system that they're working in, which we appreciate is a very difficult, complex system, not just for people that are accessing supports, but also for the people working in them. And so we walked through the experience of being a health professional, supporting someone through this process of finding and accessing support through an ED. We explored their feelings, the reasons why they felt that way, and also what needs were not being met that they could identify. Now, we broadly mapped these to what we were calling touch points, so those key points of the process, so finding people, trying to find help and connect to help, arriving at initial assessment, the waiting, if there was a waiting period, treatment, and then also leaving. So we're aware, particularly for health professionals, that they often are not involved in every step of this process. So we're just trying to gather information from the various health professionals that might be connecting to people and supporting people through one or more of these touch points. And so the following slides that Tina is going to take you through really just highlight the key points of discussion and feedback that we got from health professionals during this first phase of co-design in the health professional focus conversation. And everything that was shared in those conversations has been captured with the most common themes that are emerging that we'll be showing you now. Thanks, Tina.
Thanks, Carrie. So as Carrie explained, what we were really interested in was understanding your experience and finding out what it's like to be in your shoes when you're supporting or with somebody who is seeking help through the emergency department during a suicidal crisis. And so we asked you about what that felt like for you and really explored the reasons that you were having that experience. So the first thing we talked about was helping people or assisting people to actually access that help, to find out what they need to do in order to access help through the emergency department. And we were really lucky to talk with a number of people who worked outside the public health system, who were often, like a lot of people who were deeply involved in this stage where people had contacted them. People were in a suicidal crisis and they were supporting people to make contact with the emergency department. And we asked people what that felt like for them as a health professional. And it brought up a lot of different feelings for people, and you can see those there. So people felt frustrated, and frustrated was actually, that was the feeling that came up the most for people in this stage of supporting someone to access or find help. People felt pressured by what they needed to do in order to help the person. Some people felt extremely sad about what the person was experiencing during their suicidal crisis. There were feelings of anger. And a lot of health professionals feel that that's a very taxing time for them. There was expressions of concern and feeling concerned about whether or not the person would actually be able to access help through the emergency department. And one person told us that they actually feel quite impotent at this time, they wonder whether they're actually able to do what is needed to be done in order for the person to get the help they need. But there were also some positive feelings, so expressions of relief, relief that the person was able to be connected or was seeking help, and also optimism that this was, whilst it was a very difficult time for people, that things might be very different for them if they are able to access help through the emergency department. The health professionals we spoke to provided us some really useful information about that process of people trying to find help. So there were comments made about the stigma associated with the mental health sector, and also of distrust in the community, and that distrust of services makes it sometimes difficult to help people find the help that they're seeking. A comment was made that as health professionals, people can often be unsure about how to achieve a good outcome for the person. And another person pointed out to us that this period of finding help for people is very much defined by the fact that there are only health professionals feel there are only two options available, either to schedule or not schedule. For those who support somebody to access the ED and actually start going through that process with them, they often see that what they feel frustrated by is that the person walks out the door before they can even leave the emergency department. So a real range of experiences were shared with us there. And these are just some quotes that came from our conversation about helping people to find help through the emergency department. So calling an ambulance can be urgent and pressured. People don't know how to access information. And another person made the comment that the way you feel at that point in time is very influenced by the fact that this person feels the system is broken. So then we asked the health professionals who either work in the emergency department or who go with someone to the emergency department to seek help. And we asked them about that experience. And health professionals said, again, we had a mix of feelings. So there were positive feelings. You can see them there that some health professionals feel quite comfortable at that point in time and feel very helpful. Some other feelings that came up, again, that word frustrated, which came up quite a bit during our conversations, that it's stressful, that it can feel very awkward for people, but just acknowledging that mix of feelings, that for some people this is a very rewarding time because it's a time when there's potential for a health professional to really make a difference in what someone is experiencing. So the health professionals we spoke to provided us some additional information about what it's like for them and what it's like when people arrive and during that initial assessment in the emergency department. And we were told that one of the defining features is that no one is present. And also there was a lot of conversation around lack of privacy for people at that time. One person told us they're not bothered by the initial arrival process because from their perspective, a person who's accessing help at that time is fully monitored while they're waiting. Another person spoke about felt that during that arrival and initial assessment, they have a real desire to want to do more for someone, and that it's very defined by trying to understand a person's background, and that for some people, some health professionals were really uncertain about how to best help at that point in time. So then we asked the health professionals who are around at that time when people are waiting, because there are a number of different periods where people might be waiting after they've approached the emergency department for help during a suicidal crisis. And during that waiting period, health professionals feel annoyed and frustrated. And again, you can see that word frustrated came up quite a bit in the Griffith area. And sometimes they feel awful and stressed, but then there are other health professionals who feel quite comfortable during that waiting period. And in terms of feeling comfortable that at least the person is going to get the help that they need, and that the person is being watched and there was a sense that they were safe. We asked health professionals what they could tell us about that waiting period. And some spoke about a lack of priority for people who are experiencing a suicidal crisis. The people who worked outside the public system, so mental health workers who are providing support to people, felt that often mental health staff are not acknowledged during those waiting periods. Some spoke about even maybe they felt that people's needs were not being met because it was assumed that the mental health staff with them, the mental health support workers, would meet those needs. Some people commented that staff are very well trained for this process. but that it's difficult to see distressed people waiting. It was observed by some health professionals that maybe this is not the best environment for people to be waiting in. The person has no interactions with anyone while they're waiting, and that there needs to be more appreciation of the need to be mindful of the real issues associated with mental health. And these are just some quotes, things that people said about that period of waiting. So one person said that they felt their professional opinion was dismissed at that time. Another health professional commented that there's a lack of awareness on how to receive the person. And it was also commented that the emergency department is often viewed as only offering support for physical ailments. So a real feeling that perhaps people who are there in a suicidal crisis, that their needs might be being overlooked. So some people who approach the emergency department in Griffith for help during a suicidal crisis are admitted for treatment, and they may be sent to Wagga in order to spend some time in the mental health unit then. And we asked health professionals in Griffith how they felt at that time that people were receiving treatment. And some of the, again, a real mix of feelings amongst health professionals. So there were some positive ones, feelings of relief that the person was receiving what they need, and feeling very positive and satisfied with that as an outcome, that the person was receiving treatment. But there were other health professionals who felt frustrated again, and who had very negative feelings at that time. So when we asked for information about what was going on for health professionals while people were in Wagga receiving treatment, they said that there was relief knowing that they'd been admitted and that a plan was being developed. And there was also acknowledgement that after this, that the person might have access to mental health services in the community, although there was some conversation around those mental health services in the community being seen as the only treatment available for some people. Some health professionals spoke about being conscious that a suicidal crisis might allow access to support that the person might not otherwise have had. But also there were talks about long delays in this process. So we then asked health professionals what it's like for them when a person leaves, either after they leave at the end of approaching the emergency department for help, so leaving from the emergency department to go back to their homes or their families, but also the experience of when people leave after receiving treatment. And again, we had a mix of feelings come up here. So some people do feel relieved when someone is leaving and feel positive. There were other feelings that came up as well. Again, that word frustrated really dominated the conversation with health professionals about the experience and what it was like for them. Some health professionals really were wondering at this time when people were leaving, or were confused about why they were leaving or what would happen once the person had left. Some spoke about despairing, feeling guilt and stress, and some spoke about being very upset at this time. So we asked the health professionals, what can you tell us about this experience when people are leaving? And they said, well, sometimes there has been no admission, and that's really what defines the experience for them. That sometimes follow-up is lacking after a person leaves the emergency department or treatment. There were some comments that if a person was seen as being at low risk of suicide, that it's actually a relief to see them go rather than going into treatment. There were comments around the process being very slow and long. and that there may be support in place. And if there is support in place, that's something that definitely affects the experience of health professionals. Some services spoke about how they said we don't know what's happening for them, a lack of information, a lack of knowledge of what's going on. The possibility that nothing has been resolved for the person. And for some health professionals, a fear at the point of leaving based on anticipation of possible escalation. And some of the specific things that were said to us when we talked about people leaving is there was a questioning that with some people, where is the logic in discharging? Another person commented that it leaves me wondering if it were to happen again, will they come back due to how long it takes? So real concerns that the experience that the person has been through might mean that they never access help again. One person in particular spoke and helped us to understand what it's like to be blamed by other people for the person being discharged. So that person said, you can be the scapegoat for family and friends who are upset that their family member has been discharged or nothing was done. So just generally about the experience of walking in a health professional's shoes when somebody is seeking help during a suicidal crisis through the emergency department, feelings of distress, feelings of being frustrated and being unhappy. And some general comments about that process were concern that when people leave, they will go back to the same situation. A lot of concern expressed that the new hospital in Griffith has no mental health unit. And so that means that people need to go to Wagga in order to have access to the care of a mental health unit. That it's a very long and delayed process of assessment, and that causes people distress, and that low risk mental health patients are only admitted through their GP. Also, the comment was made that there are not enough resources and people don't know what to do. And just a few general comments that were made during our conversations. One person said, it's an ongoing cycle that we don't seem to be addressing. Another person said, it's not that we don't care, it's just total frustration with the system we currently have. And another person observed that we are not actually reaching out to our local Aboriginal community to support before they reach crisis point. So this led to a conversation about what might be needed. And this will be an ongoing conversation. We'll be meeting with health professionals again, and we'll really be getting some clear pictures around this. But in terms of what health professionals in the Griffith area need to feel comfortable with supporting people to access a safe space as a genuine alternative to the emergency department, there are a lot of comments made about the environment and the atmosphere that needs to be in place in a safe space, and also about the peer workers, the suicide prevention peer workers who'll be working in them. So health professionals told us that they need it to be a welcoming, safe and secure space. So in terms of it being a secure space, there was some concern about how security might be maintained in these safe spaces, and that if people don't feel that if they're secure spaces, that they won't feel comfortable approaching them. People need to know they're going to get support from understanding people. Health professionals would like to see peer workers who are trained and are supported and have access to appropriate resources. And there was a lot of talk from people in the Griffith area about the need to meet the professional needs of the suicide prevention peer workforce, and also provide them the adequate supervision to make sure that they have what they need to deliver that really important service. Health professionals told us that they would like the space to be staffed by non-judgmental peer workers who understand and who are there to listen and to support the person. And that there needs to be a certain level of specific training completed by these peer workers in order for health professionals to feel comfortable supporting people to access their support. It's important to health professionals that people don't feel intimidated to go into a safe space. And we were lucky to get some really specific comments around the needs of youth who might be accessing, young people accessing the safe space. So that maybe there needs to be a separate space for youth that means that they can access that space and it be a separate space to what's used by adults. They said that we should consider a mentoring program for youth. People really want to see it, health professionals want to see it set up as a non-clinical, compassionate and comforting space for support. That there needs to be no set time frame that people will have to follow in terms of accessing that support. And there was a comment that one health professional said that they want to see the space staffed by compassionate peer workers. And they made it clear that what they meant by that was for the health professional to feel comfortable supporting people to go there, they need to know that it's not just helpful volunteers or people who are there for self-gratification.
Thanks, Tima. So as you can see, we got a lot of really rich information just from those focused conversations. And then, of course, we've had the webinar earlier today that fed back the information we got from the lived experience participants, and we really acknowledge just how just the depth of insight, as well as the people's just willingness to share their lived experience, not just their direct lived experience, but also the lived experience as health professionals of working in such a difficult system. As you can see, there's some of the comments there and the feedback that we're getting, and we do just really appreciate how people bring so much of themselves to these processes and the time and energy that's required. So now we'll just give anyone that's actually watching live an opportunity to ask any questions that you may have. We'll just give you a couple of minutes if there's anything that you want to ask. If there's something that you go away and then think of, you're more than welcome to always email Roses in the Ocean. We're always open to getting more feedback directly from co-design participants or answering any questions. But if there are any burning questions that people have now, feel free to ask Tina and I. We'll just, while we're waiting, just to give people a bit of information. So as part of this feedback loop one, that's what we're calling this, there will be a survey. So you see here, there's the link to it. That'll also be on the landing page of your LHD on the Roses in the Ocean website. As we always say, it's super important to get as many people involved in participating in these feedback loops. So if you can get people to watch the webinar, to look at the information captured, to follow up with the survey, answering the survey, because we can't get that many people in the room of directly participating in the workshops. That's an even smaller group of people when you're doing these things virtually, trying to do co-design virtually. And we really know how important, and it really is emerging in the literature, that if you get a very broad and diverse range of perspectives in local co-design processes, you are more likely to develop service models that will, when they're implemented, you know, be more effective and sustainable for meeting the local needs and wants of communities. So it's really important, if you can, to let your informal networks know that this process is going on and get them to have their say. It doesn't look like there are any questions. So just to briefly wrap up with next steps, Tina, thanks. Oh, there is one here from Sharon. From those consultations, were there ideas as to a location for this safe space, e.g. on hospital grounds? It's an excellent question, and it's actually specifically one that we posed in the combined session, where we start to look at what are the things like location, like connections in and out of the safe space in terms of connections to other services. All of those things will be worked out very specifically, particularly mapped against the ministry requirements, because there are some requirements about the service model, and we'll be doing that in the final combined session. We'll be talking to health professionals a bit more. It says here session 2, where you're provided with some of the lived experience ideas of how to meet the needs and wants of community in your local region in terms of what a safe space should look like. So that those things will start to come up in that next session. I believe that is the 9th of November. Correct me if I'm wrong, Tina. I'm not sure if you've got that here, but yeah, so on the 9th, we can start to have a look at those more specific questions. It also, obviously, we know that it depends on sort of the organisational constraints and the resources of an LHD and what those requirements are. So what we can do is feedback that information as we receive it from LHDs. So we're able to let you know, hopefully in real time, as those decisions are being made, or certainly what, if there are any hard boundaries around those things, we can communicate that throughout the co-design process. So as you can see, we're just going through this feedback loop 1 now. So the webinar and then the survey questions, then that health professional session 2, which is a couple of hours where you really get to have a look at that emerging service model and provide your own comments and further feedback. And that's on the 9th of November. Then we'll have another feedback loop, just like this, same process, feeding back all of the outputs that have been generated by then. Then there's that joint stakeholders, what I'm called the combined session 3. And that's where all of those things will be determined, like location. And then we'll have a final feedback loop, which will be, again, the same sort of process, but where we can really communicate the outputs generated from this process. And that will be the service model that then will be reported on and to the LHD. So if there are no more questions, thank you so much for joining us today for this webinar. As I said, spread the word to your networks and let them know. We really want to get as many people in your community to participate in this co-design. So thank you very much, and we'll see you soon.